Welcome to the Hospital Medicine Unplugged podcast. Today we are undertaking an extensive deep dive into one of the most clinically relevant tachyarrhythmias we manage in the acute care setting, atrial flutter, or A-flutter. Our mission today is really to systematically analyze and extract the essential evidence-based clinical practice guidelines, specifically around the diagnosis and management of A-flutter in our hospitalized patient population.
Yeah, this is a critical discussion. While atrial fibrillation gets a tremendous amount of focus, A-flutter is actually the second most common atrial tachyarrhythmia, and it frequently complicates acute illness and structural heart disease in the patients we admit. So we're going to consolidate the current guidance from the American College of Cardiology, the ACC, the American Heart Association, AHA, and the Heart Rhythm Society, HRS. And we'll synthesize those with recent network meta-analyses to provide, hopefully, a unified, consolidated approach for your bedside practice.
Absolutely. And it's often the nuances that really matter here, especially when you're trying to differentiate A-flutter from AF. Because that subtle difference, well, it dictates the entire therapeutic strategy, doesn't it? So before we jump into specific drug choices and interventions, let's anchor ourselves in the fundamentals, the clinical picture, the pathophysiology that defines this condition.
Indeed. The mechanism really dictates the management strategy. A flutter is exceedingly prevalent among hospitalized patients. We tend to see it most often in individuals with underlying cardiac pathology. So that means patients with heart failure, significant valvular disease, or perhaps most predictably, patients who are status post-cardiac surgery. The acute inflammatory state, the volume shifts that accompany any acute hospitalization, these can serve as powerful triggers for this arrhythmia.
Right. And the reason we absolutely must manage it aggressively in the hospital setting is because the clinical consequences can be quite severe. A rapid ventricular response in A-flutter can dramatically compromise cardiac output, especially in someone who might already have depressed systolic function. And crucially, it also carries a significant risk of thromboembolic events, a risk that's really comparable, mirroring the risk profile we associate with atrial fibrillation.
Exactly. And to understand why A-flutter behaves differently than AF, we really have to look at the electrophysiology. A-flutter is what we call a macro-reentrant atrial tachyarrhythmia. Now, the most common form, which we term typical A-flutter, is cavo-tricuspid isthmus-dependent. This implies there's a large, stable reentrant circuit, and it's localized within the right atrium. This circuit cycles around the tricuspid valve annulus, and critically, it must pass through that specific bridge of tissue known as the cavo-tricuspid isthmus, or CTI.
That level of anatomical specificity is interesting because it means the diagnosis itself points straight towards a potentially curative procedure ablation, which is a key difference from managing most AF. But when we look at the ECG, how does that stable focus circuit translate into the signature findings we rely on in the acute setting?
Well, that stable circuit translates directly into a stable rapid atrial rate. It's typically regular, running somewhere between 240 and 300 beats per minute. This highly organized circular activation produces the classic sawtooth pattern of flutter waves that we look for. And we usually find these flutter waves are most prominent and often negatively deflected in the inferior leads. That's leads 2, 3, and AVF. This is really the visual anchor for the diagnosis.
Okay, now what about the ventricular response? Because while the atrial activity is organized, the resulting pulse rate is often what sends the patient into distress or gets our attention.
Right. The ventricular response is most often determined by a fixed AV conduction block, typically 2-to-1. The AV nodes simply can't recover fast enough to conduct every single impulse when they're coming down at 250 or 300 BPM. So for every 2 atrial impulses, usually only 1 gets conducted to the ventricle. This results in a regular ventricular rate, often around 120 to 150 beats per minute. That regularity is the key physiological signature. Now, if the atrial rate slows down a bit, maybe, or if the patient is already on some rate-controlling agents, you might see 3-to-1 or even 4-to-1 block. That would result in slower ventricular rates, maybe 75 to 100 BPM, still regular though.
Differentiation from atrial fibrillation, which, as you said, often presents with similar fast rates, is clearly essential because, like you mentioned, the therapeutic strategies really diverge, especially when we start thinking about things like ablation. So what are the absolute critical points we must use to distinguish the two when a patient is newly admitted with a fast rhythm?
The primary distinction really lies in the organization of the atrial activity. A-flutter has those organized, discrete flutter waves we talked about, and typically a regular ventricular rhythm because of that fixed AV block. AF, by contrast, is characterized by chaotic electrical activity that manifests as the classic irregular rhythm, and it lacks any discrete, discernible flutter waves. It just looks, well, chaotic.
But I think every hospitalist has probably been burned by this particular clinical pitfall. A flutter that develops variable AV conduction.
Ah, yes. That is precisely the most frequent source of misdiagnosis in the acute setting. It's a common trap. If the AV block becomes variable, let's say it fluctuates randomly between 2-to-1 conduction and then maybe 3-to-1 or 4-to-1 conduction, the resulting ventricular rhythm becomes irregular. So when the rate slows down for a beat or two and then speeds up again, this irregularity can deceptively mimic atrial fibrillation. And because many patients might have a history of both arrhythmias, mislabeling an irregular A flutter as AF can lead to an inefficient or maybe even an incorrect therapeutic pathway. For example, we might not consider specific rhythm control agents like ibutilide, which is highly effective for flutter, but generally less so for true AF.
That really underscores why meticulous review of those inferior leads for the sawtooth waves is absolutely mandatory, even if the overall rhythm strip looks generally messy or irregular at first glance. Okay, so we've established the ECG diagnosis. What role does imaging, specifically echocardiography, play in the initial management of A flutter in a hospitalized patient?
Transthoracic echocardiography is pretty much mandatory and recommended by guidelines for several key reasons. Primarily, of course, we need to assess for underlying structural heart disease. We want to quantify chamber size, evaluate ventricular function, look for significant valvular pathology. Things like severe mitral or tricuspid regurgitation, which can either precipitate the arrhythmia or sometimes be a consequence of the rapid heart rate itself. But there's also a more subtle diagnostic nuance with echo. Because the atrial circuit is so organized, you can sometimes actually see regular synchronous undulatory motion of the posterior left atrial wall and maybe the upper left interventricular septum on the echo screen. And this motion visibly coincides with each flutter wave seen on a simultaneous ECG tracing. It sort of confirms the mechanical reality of that Macquarie entrance circuit.
That's a fascinating detail for the bedside physician. It really bridges the electrical diagnosis with mechanical consequences you can visualize. Okay, let's unpack this a bit and move into the immediate clinical application side of things. What does the triage sheet look like, metaphorically speaking, for a patient presenting to the hospital in A flutter? Well, when a patient arrives in A flutter, the initial clock really starts ticking on rapid assessment. We absolutely must determine hemodynamic stability. That's paramount. But just as important is a diligent search for any precipitating factors. The common culprits, things like an acute infection, severe electrolyte disturbances, especially hypokalemia or hypomagnesemia, or maybe medication toxicity, particularly from digoxin or even antiarrhythmic drugs themselves. These must be identified and corrected immediately. Sometimes just fixing the trigger resolves the arrhythmia.
Identifying those triggers is foundational, absolutely. But the second, and perhaps most regent step, is addressing any instability. In the hospital, we need to define hemodynamic instability strictly. Is there new or worsening hypotension? Frank shock. Evidence of ongoing active myocardial ischemia? Or maybe acute/pulmonary edema due to severe heart failure that's clearly precipitated by the rapid rate.
And in any of those scenarios, the guidelines are very clear. Immediate synchronized electrical cardioversion is the preference. We really shouldn't delay making that decision by first attempting pharmacologic conversion or even aggressive rate control.
Exactly. That preference is driven by the immediate danger posed by pharmacologic intervention in this unstable setting. Most of the effective rate-controlling agents, like beta blockers or diltiazem, carry the inherent risk of negative inotropy. So administering these to an already hypotensive patient or one in cardiogenic shock could actually exacerbate the shock state, potentially pushing them over the edge. Electrical cardioversion, conversely, offers the most rapid restoration of sinus rhythm and, hopefully, optimal cardiac output with minimal intrinsic drug risk. And the initial energy settings are often lower than what you might use for AF, typically starting around 50 to 100 joules because of the organized nature of that flutter circuit.
Okay, so shifting gears now to the majority of patients, we see the ones who are hemodynamically stable. For them, the first-line goal is achieving adequate rate control. And here we rely on our standard AV nodal blocking agents, beta blockers, or the non-dihydropyridine calcium channel blockers, so diltiazem or verapamil.
Right. And in the acute inpatient setting, intravenous diltiazem is often a preferred agent for initial rate control. It has a rapid onset and it's easily titratable. However, this is precisely where we often encounter that significant clinical challenge that seems somewhat unique to A flutter. Because the atrial rate is so organized and so rapid, 250, 300 BPM, the drive to the EV node is just unrelenting and very predictable. This means rate control is frequently significantly more difficult to achieve in A flutter compared to AF. We often find ourselves needing higher doses, sometimes pushing the limits of the patient's blood pressure tolerance. Or we might need combination therapy, say a calcium channel blocker plus a small dose of a beta blocker just to achieve an acceptable ventricular rate, usually aiming for below 100 BPM.
Yeah, that clinical resistance to rate control often pushes the team towards considering rhythm control earlier than they might in a similar case of AF, doesn't it? But before we explore rhythm control options further, we absolutely must slow down and discuss the crucial contraindication. This is one that, if ignored, can lead to catastrophe. AV nodal blockers, so beta blockers, calcium channel blockers, and digoxin are strictly contraindicated in patients who have pre-excited A flutter.
This caution is paramount. It's perhaps the highest yield teaching point in all of A flutter management, honestly. If an accessory pathway, like you see in Wolff-Parkinson-White syndrome, is present, the patient's ventricular rate is determined by conduction down both the AV node and that accessory pathway. Now, AV nodal blocking agents do exactly what their name implies. They block the AV node.
Right, but crucially, they don't block the accessory pathway.
Precisely. So by blocking the AV node, you effectively shift the entire conduction burden onto that accessory pathway. And this pathway, unlike the AV node, has no decrement, no protective slowing mechanism built in. It can conduct impulses extremely rapidly.
So the flutter impulses that were previously being partially blocked or at least slowed by the AV node are suddenly shunted down this open high-speed circuit.
Exactly right. And this acceleration can easily result in one-to-one conduction from the atrium down to the ventricle. That could potentially lead to ventricular rates well over 200 beats per minute and often degenerates rapidly into a chaotic ventricular fibrillation. So given that many patients presenting to the hospital might have uncharacterized heart rhythms, maybe unknown accessory pathways, we must always consider this risk when we're initiating AV nodal blockers for any wide complex tachycardia, or even for A flutter if the baseline ECG or history is unclear.
That is such a critical mechanism to remember.
Okay.
If we connect this to the bigger picture then, once we've stabilized the patient, maybe achieve some rate control, we face the decision. Do we stop at rate control or do we pursue active rhythm control?
Well, while large meta-analyses, particularly those focused on AF, have suggested that a primary rhythm control strategy doesn't necessarily offer a global mortality benefit over rate control alone, and in fact, may even increase adverse events due to side effects from antiarrhythmic drugs. Rhythm control does remain a preferred strategy in certain hospitalized populations with A flutter. Specifically, we should consider conversion for patients who remain severely symptomatic despite achieving what seems like adequate rate control. Or, perhaps more commonly, in patients where rate control proves persistently challenging because of that inherent resistance of the A flutter circuit we discussed.
And when rhythm control is deemed necessary, electrical cardioversion seems to remain the preferred rapid method, especially in the hospital setting.
Its benefits are really hard to beat in that context. Electrical cardioversion boasts high acute success rates, often approaching 98 to 100% for typical flutter, and it carries an extremely low procedural risk overall. Plus, for A flutter, unlike AF, the electrical energy required to interrupt that single stable macro-reentrant circuit is generally lower. This high efficacy is why, assuming the patient's anticoagulation status allows for it, electrical cardioversion should always be favored when a rapid return to sinus rhythm is the goal.
Okay, but what if we opt for pharmacological cardioversion in a stable patient? Perhaps it's someone where we are quite certain of a very short duration of the arrhythmia, maybe less than 48 hours. Which agents offer the best chance of conversion pharmacologically?
Network meta-analyses give us some clear comparative data here. Agents such as abutolide, tofidilide, sotalol, and propafenone have all demonstrated superior efficacy for acute conversion to sinus rhythm, particularly when compared to amiodarone, which tends to be a slower and often less reliable conversion agent specifically for A flutter.
Abutolide is often favored in the acute care setting, partly because of its rapid onset and high conversion efficacy specifically for flutter. What are the specific monitoring requirements that absolutely must be adhered to when we administer it?
Right. Abutolide is a class 3 antiarrhythmic, and its administration requires very careful, continuous telemetry monitoring. That's non-negotiable. The primary risk is dose-dependent QT prolongation, and along with that comes the associated risk of inducing torsades de pointes. Now, this is usually a transient risk, but it's a serious one. It requires the patient to remain in a highly monitored environment, usually telemetry or ICU, for at least 4 to 6 hours after the infusion is complete. And we need to ensure they are adequately hydrated and have optimized potassium and magnesium levels before we even start the infusion.
Also need to be exceedingly cautious with the class I antiarrhythmic agents, specifically thinking about flecainide and propafenone, even in a patient we know doesn't have pre-excitation.
Yes, the necessary caution around class I agents is critical, and it relates directly back to that A-flutter mechanism we keep discussing. These agents work primarily by blocking sodium channels, and that action slows conduction velocity within the atria. By slowing conduction, they can actually slow the flutter cycle rate itself.
So the 2-to-1 block that might have been protective before, at a faster atrial rate, could potentially resolve if the atrial rate slows down enough.
Exactly. If the flutter cycle slows too much, let's say it drops from 280 BPM down to 200 BPM, the AV node might suddenly be able to keep up and conduct every single beat. This creates the risk of inducing 1-to-1 AV conduction, which can suddenly cause a dangerously rapid ventricular rate, potentially up to 200 BPM or even faster, which is often hemodynamically intolerable. Therefore, if these class I agents are ever used for rhythm conversion of A-flutter, they absolutely must be co-administered with an AV nodal blocker, like a beta blocker or diltiazem, to protect the ventricle and maintain an adequate degree of AV block. Provided, of course, that we've definitively ruled out pre-excited flutter first. This complexity often makes other agents, like abutylide or electrical cardioversion, preferable in the acute inpatient setting.
That dual drug requirement really highlights the inherent complexity and potential risks there. Okay, finally, in this section, let's discuss the role of catheter ablation. We know it has exceptionally high efficacy for typical A-flutter, sometimes even considered in the acute setting.
Yes, catheter ablation is highly effective, bordering on curative, especially for that CTI-dependent typical A-flutter we've been focusing on. The procedure targets and destroys that single critical isthmus of tissue, the CTI, permanently interrupting the reentrant circuit. It really is the gold standard recommended therapy for recurrent or refractory cases because it offers superior long-term maintenance of sinus rhythm compared to relying on antiarrhythmic drugs long-term. And the success rates for CTI ablation are routinely quoted as being above 90%, which is quite remarkable.
But it's interesting that the guidelines now even support considering ablation acutely, sometimes in critically ill hospitalized patients.
That's right. In situations where pharmacological attempts and even electrical cardioversion attempts have failed to achieve stable rhythm or adequate rate control, and the patient remains hemodynamically tenuous because of the flutter. Moving rapidly towards a CTI ablation might actually be the fastest route to stabilizing their rhythm. This really underlines ablation's role not just as a long-term cure for recurrent flutter, but potentially as a critical rescue therapy in some of the direst clinical situations, leveraging the anatomical predictability of that typical flutter circuit.
Okay, excellent. Let's now shift gears to what is arguably one of the highest stakes management decisions we make in A-flutter, assessing thromboembolic risk and applying the correct anticoagulation protocols. I think the core message here, the one that must be clearly communicated to the patient, the family, and the entire care team, is that anticoagulation guidelines for A-flutter essentially mirror those for atrial fibrillation. We treat the stroke risk as functionally equivalent. And this is well supported by evidence demonstrating that atrial stasis and left atrial appendage thrombus formation are indeed prevalent in A-flutter. This translates to annual stroke rates averaging somewhere around 3%.
That equivalence is key. It means we utilize the exact same risks stratification tool that we use for AFP, the CHADS FAST score. Anticoagulation is generally recommended for male patients scoring 2 or greater and for female patients scoring 3 or greater on that scale. And this risk assessment must be done immediately upon admission, really regardless of whether the initial plan is rate control or rhythm control.
Let's focus intensely for a moment on the pericardioversion management, because this is where some of the most common clinical errors can occur. We're talking specifically about patients where the duration of A-flutter is either unknown or it's definitively known to be 48 hours or longer. For an elective cardioversion in this scenario, the standard protocol requires at least 3 full weeks of therapeutic anticoagulation prior to the procedure.
Right, that 3-week period is considered essential. It allows any potential pre-existing thrombus, which might be loosely attached in the atrium or appendage, to organize and adhere more firmly to the atrial wall. The idea is this reduces the risk of that thrombus embolizing upon the restoration of sinus rhythm and atrial contraction. The guidelines confirm that either a vitamin K antagonist like warfarin, achieving a therapeutic INR, or any of the direct oral anticoagulants, the DOACs, are effective and safe options for this preparatory period.
But often in the hospital, we face pressure to urgently convert a patient who might be unstable or highly symptomatic. What if the duration is unknown or known to be over 48 hours, but we feel we cannot wait 3 weeks?
Yes, this is the critical juncture where practice often deviates from the elective pathway. For urgent cardioversion of an arrhythmia of unknown or prolonged duration, performing a transesophageal echocardiogram, a TEE, specifically to definitively exclude a left atrial appendage thrombus, is considered a reasonable and often necessary alternative to that 3-week waiting period. If the TEE is clearly negative for thrombus, then we can proceed immediately with cardioversion.
Okay, and the decision-making isn't over just because the shock was delivered successfully. The post-cardioversion anticoagulation protocol is often overlooked, but it's absolutely non-negotiable. Therapeutic anticoagulation must be maintained for at least 4 weeks after the conversion.
That mandatory 4-week duration is critical, and it applies irrespective of whether the initial TEE finding was negative or whether the patient received the full 3 weeks of anticoagulation beforehand or not. The rationale behind this is the phenomenon known as atrial stunning. Following successful electrical or even pharmacological conversion, the mechanical function of the left atrium, and particularly its appendage, remains stunned or temporarily paralyzed for several weeks. This mechanical dysfunction creates a temporary state of profound blood stasis, even though the patient is in sinus rhythm electrically. This maintains an elevated risk for delayed embolic events, making that 4 weeks of mandated anticoagulation absolutely essential for stroke prevention during this vulnerable period.
And conversely, what if the pre-procedural TEE does find a thrombus?
If a thrombus is identified, then cardioversion must be deferred immediately. The priority shifts entirely to resolving that clot safely. The patient must receive a minimum of 3 to 4 weeks of uninterrupted therapeutic anticoagulation, sometimes even longer depending on the clot characteristics and follow-up imaging. Only after that period, and ideally with repeat imaging confirming thrombus resolution, should a subsequent cardioversion attempt even be considered. We have to prioritize preventing a devastating stroke over the immediate gratification of achieving sinus rhythm.
Absolutely clear.
Okay.
Next, let's move into the highly complex territory of managing A-flutter in special populations, discussing potential complications and the importance of long-term surveillance. These are often the most challenging cases we see admitted to the hospital.
We can start with a common scenario. Managing A-flutter in patients with heart failure with reduced ejection fraction, or HFrEF. This group presents a unique pharmacological puzzle because we're constantly trying to control the heart rate without further compromising their already weakened pump function. Specifically, the non-dihydropyridine calcium channel blockers, that's diltiazem and verapamil, should generally be avoided in HFrEF due to their significant negative inotropic effects, which can easily precipitate acute decompensation.
Okay, so if those are out, which agents do we typically rely on for rate control in the HFrEF population?
Beta blockers are generally the preferred first-line agents for rate control, assuming the patient is in a compensated state of heart failure, and they can be initiated or up-titrated carefully without causing undue bradycardia or hypotension. However, for more acute rate control, where we need rapid efficacy but want to minimize the immediate risk of worsening heart failure compared to calcium channel blockers, amiodarone is often considered a reasonable option. It carries less negative inotropic risk, but its own toxicity profile and relatively slow onset of action are definite drawbacks.
And what about rhythm control options specifically tailored for patients with HFrEF?
The Fetolide is really a cornerstone antiarrhythmic in this population, as landmark trials have shown it's safe to use in patients with heart failure, unlike many other antiarrhythmics. However, its use requires inpatient initiation and a strict multi-day monitoring protocol. This protocol is typically dictated by specific QT interval targets and the patient's renal function, all designed to mitigate the risk of torsades de pointes. This necessity of a prolonged, closely monitored inpatient stay means it's usually reserved for patients who are already admitted, perhaps for decompensation or refractory arrhythmia, rather than being a quick fix.
Moving on, post-cardiac surgery patients are in another very high-risk group where A-flutter is tremendously common. It's often triggered by the severe atrial inflammation and the direct surgical trauma to the atria.
Exactly. That postoperative inflammatory state makes the atria highly irritable and prone to re-entry circuits. Initial management in the hemodynamically stable post-op patient is usually rate control, often with beta blockers if tolerated. But because there's a high likelihood of spontaneous resolution once that initial post-op inflammation subsides over days to weeks, we often lean towards considering aggressive rhythm control earlier, aiming to reduce hospital length of stay. For pharmacological conversion in this specific setting, both amiodarone and ibutylide are considered effective choices, again with appropriate monitoring.
And given the potential for associated sinus node dysfunction, maybe due to the proximity of the surgical lesion sets, especially here the SA node, what kind of approach is necessary there?
A multidisciplinary heart team approach is really highly recommended in these complex post-op cases. You ideally want cardiology, electrophysiology, and the surgical teams all aligned on a strategy, especially if temporary pacing wires are still in place, which adds another layer of complexity. Plus, the presence of those surgical lesion sets or scar tissue can also generate atypical flutter circuits, making the diagnosis and subsequent management, like ablation, potentially much more complex than simple typical CTI flutter.
Right. Finally, in this complex group, let's address the patient with refractory or recurrent flutter, the one that unfortunately keeps coming back for readmission despite initial therapies.
For symptomatic refractory typical A flutter, the CTI-dependent kind catheter ablation really transitions from just being an option to being the established first-line therapy. Given those success rates consistently exceeding 90%, it arguably becomes clinically necessary to pursue ablation relatively quickly in this scenario to prevent further recurrences and hospitalizations.
But as you alluded to, ablation for non-CTI dependent, or what we call atypical flutter, is a very different beast entirely, isn't it?
It is significantly more complex, yes. Atypical flutter usually results from areas of scar tissue in the atria, perhaps related to prior cardiac surgery, prior AF ablation procedures, or other underlying atrial pathology. These circuits are not confined to the CTI and can occur almost anywhere in either atrium. Identifying and ablating them requires detailed, sophisticated electroanatomical mapping, often involving advanced 3D mapping systems tailored specifically to the patient's unique scar geography. The success rates are generally lower than for typical flutter, and these procedures are usually best reserved for experienced, high-volume tertiary electrophysiology centers.
If we connect this to the bigger picture now, thinking about the long-term sequelae of A flutter really underscores why effective acute management is so critical and why we need to emphasize long-term rhythm monitoring as well. What are the key complications of untreated or recurrent A flutter that we absolutely must strive to prevent?
Well, the primary risk, as we've heavily discussed, is thromboembolism, stroke, or systemic emboli. That's always front and center. But the secondary risks are also substantial. A persistent, rapid ventricular response invariably exacerbates underlying heart failure, potentially creating a vicious cycle of admission and readmission for decompensation. Crucially, studies show that up to 50% of patients initially presenting with A flutter will eventually develop incident atrial fibrillation over time. A flutter is often seen almost as a transitional arrhythmia for many patients. This progression further increases the patient's long-term risk burden and certainly complicates future management strategies. And finally, looking at population data, cohort studies consistently demonstrate that the presence of untreated or recurrent A flutter is independently associated with roughly a twofold increase in all-cause mortality compared to matched controls without the arrhythmia.
Wow, that 50% progression risk is really striking. It clearly means that long-term surveillance is non-negotiable, even after a successful conversion back to sinus rhythm or even after a successful ablation.
Absolutely. Patients require some form of long-term rhythm monitoring, whether that's through periodic ECGs, extended external monitors, or even implantable loop recorders or device checks in those who have pacemakers or defibrillators. This is crucial due to that substantial risk of subsequent incident AF, which might be asymptomatic but still carries thromboembolic risk, even if they had a successful CTI ablation for their flutter. Furthermore, ongoing anticoagulation decisions must be continuously reviewed. They shouldn't be based merely on the rhythm strip at one point in time, but rather based on the patient's persistent thromboembolic risk factors as measured by the CHADS VASC score and any documented arrhythmia recurrence. The decision to stop anticoagulation, even after flutter ablation, should only be made with great caution, regular follow-up, and usually only if the underlying stroke risk score becomes very low.
Okay, let's unpack this then and try to synthesize our core takeaways from this deep dive. It seems clear that the hospital management of A flutter is distinct from AF in several key ways and really requires rigid adherence to specific protocols. The key clinical differences that stand out include the often greater difficulty of achieving adequate rate control due to that organized electrical drive, the generally high efficacy and often preferred use of electrical cardioversion for rapid rhythm restoration, and, critically, the strict necessity of AV nodal blocker avoidance in any patient where pre-excitation cannot be definitively ruled out because of that profound risk of inducing VFib.
Yes, those are central points. We must also acknowledge, though, the critical gaps in care that current literature and observational data identify. There appear to be significant disparities in the utilization of definitive conversion therapies. Data shows lower rates of ablation and sometimes even electrical cardioversion among elderly patients, females, and certain racial and ethnic minorities, even when clinically indicated. Furthermore, the evidence base for optimal drug management in the specific setting of acute heart failure, particularly HF-REF coexisting with A-flutter, remains somewhat limited. Management often relies more on expert consensus and extrapolation from AF data rather than large randomized trials specific to flutter in HF. And we still need more robust data on how our different treatment strategies, rate versus rhythm control, ablation timing, ultimately impact long-term quality of life and hospital readmission rates for these patients.
That definitely highlights areas for future research. And it raises an important question, perhaps a final provocative thought for you, the listener, to consider. Especially given those high rates of progression from A-flutter to AF, potentially up to 50%, and the proven superior efficacy of CTI ablation for achieving long-term rhythm maintenance in typical A-flutter. Should catheter ablation be considered earlier in the treatment algorithm for typical A-flutter? Should we maybe move it up the ladder, perhaps considering it even before symptoms become fully refractory to initial medical therapy, especially given its high potential cure rate and the ability to avoid long-term antiarrhythmic drug exposure and side effects?
That is a fundamental question, and one that I think will continue to shape future guidelines and practice patterns, potentially moving ablation from primarily a treatment of recurrence or last resort towards becoming a more primary treatment of choice for many patients with typical A-flutter. Thank you for joining us today for this in-depth discussion on atrial flutter management in the hospitalized patient.
And thank you for tuning into this deep dive.